Very good afternoon to one and all present here. So today we have a really informative session that's going to happen about cancer and getting aware about cancer and what we can do as part of the society to help those with cancer and uh, just know a little more about cancer. So I would request Rotaract Soumya to please introduce the speaker for the day and also take the session forward.
Thank you, Vasuki. So, talking about Dr. Manjunath Sastry, he is a consultant surgical oncologist and a minimal axillary surgeon at Shri Shankara Cancer Hospital and Research Center. With over 25 years of experience in the field, he is an expert in surgical management of cancers of the head, neck region, stomach, colon, breast, ovaries, and uterus through both open and laparoscopic approaches. Dr. Shastri is also a faculty member for the super specialty training courses such as DNB and fellowships. He is actively involved in activities aimed at improving treatment outcomes by maintaining high quality clinical protocols, providing a holistic support care, and training clinical and also non clinical staff in patient management. He is passionate about increasing awareness about cancers and educating the community on cancer prevention. Uh, we are honored to have you in this talk, sir, and handing over to Dr. Professor Shastri.
Thank you, Soumya. Am I audible? Hello?
Yes, sir.
Am I
You are
audible?
Yes, sir.
Just a minute. I'm getting the slides sharing ready. Thank you, Soumya, for your generous introduction about me. And on behalf of Shankara Cancer Hospital and Research Center, and I would like to thank each one of you to call me for the talk. So I would like to start the program with a small introduction about our hospital, Shri Shankara Cancer Hospital and Research Center. To follow it with the talks about 3 important cancers affecting men. Actually, they're 3 important, not only from the point of view of incidence, but also from the point of view of mortality. So, with the blessings of Jagadguru Shri Bharati Tirtha Swamiji, we started off our Shankara Cancer Foundation in 2010. So ours is a young hospital. We started off with an objective of providing high quality, comprehensive cancer care, accessible to, affordable and equitable to all members of the society, irrespective of the caste, creed, religion, and socio-economic status. Treatment to be highly subsidized by reducing the cost, the base cost also, and about 10% of the bed and the services are given completely free to the patients. Another important aspect objective was basically the reduce the incidence of cancer and in the rural areas and detect the cancer in an early stage. So basically, all of us have been treating the patients in the hospitals for a long time. But the importance there lies in that looking at the rural areas and try to reach them directly and try to pick up the cancers at an early stage. Because as all of us know, that cancer, if detected early, is curable. Now, because these people in the rural areas have their own issues to handle, and they may not be able to come to the hospital or the cities to reach the health services, it was decided that we should give importance to this aspect of the in this aspect of the treatment, because not only we have the we do have a lot of responsibility in the society. So with this background, our we started off with a National Center for Cancer Prevention and Research. Here we have adopted district of Chikbalapura, and there are about more than 1,000 villages in the district, of which we have already covered nearly 300 villages and reached about more than 2.5 lakhs of population. From Shankara Cancer Hospital, we go to the villages in 5 days in a week with our own vans, and there we go house to house looking at the patients or the population basically to do the screening programs for the oral cavity and looking for the oral cancers, and educating them about tobacco, the side effects of tobacco, the deleterious effects of tobacco smoking and smokeless tobacco as well. We also do a screening program for the breasts in the female and cervical cancer. So this is the program that we have undertaken by adopting the district of Chikbalapura. Further, another important objective is to develop the Center for Research under eminent scientists and medical professions to drive the research activities towards the reducing the burden of cancer in the society and improving the standards of care. So we have a cutting edge of science, because most of the research are happening in the West, and only recently that things have changing towards the developing countries also. But many of the times we realize that the most of the cancers that are there in the Western society behave differently from what we see in India. More so, we do see the cancers coming up in an early stage, or early younger patients in Indian population, and we find that they are more aggressive compared to those uh, those in the Western society. So the behavior of cancer is much different in Indian population or the South Asian population. So we have to to look into these things in a different angle. The other is to provide assistance in cancer care with a non-profit motive. So in 2012, August 15th, we started off with our radiotherapy unit and daycare chemotherapy services. And 2014, we started our surgical cares, and we have 8 operational functioning operation theaters at present. MRI and palliative care facilities were started in 2015. In 2016, we inaugurated our Shri Shankara Cancer National Center for Cancer Prevention and Research, and also the opening of breast cancer or breast diseases. Commencement of Nitya Annadana Seva scheme was also started in the same year. 2017, the inauguration of Ethics Committee and Academic Advisory Board was carried out to facilitate our research programs. Also, same year, we had the starting of our postgraduate training programs. To improve the nursing care, we also thought of starting the BSc nursing course. And in the last year, that is 2019, we inaugurated our Shri Shyamji Agarwal Center for Lung Diseases and Pediatric Long Stay Center. Lakshmi, that is Lakshmi Children Healthcare Center. In 2020, as there was a need for expansion, we acquired the adjacent building to place our Shankara Pharmacy and Shankara Physiotherapy Department. So at present, we are doing about 300 surgeries in a month. We carry out all the types of surgeries, including minimal access surgery, and we are looking forward to acquire a robotic unit, maybe by the middle of the coming year. We are doing about 200 chemotherapy in the month. The separate daycare units, which is catering to about another 100 daycare chemotherapies. Radiation is about 150 to 175 radiation therapies per day, and which is we are going to acquire another radiation unit by the mid of the coming year. The pediatric oncology and palliative care services are also doing well, with domiciliary care being provided for our patients who require palliative care as well. There are some special initiatives that have been taken to help our patients and the patients' relatives. We have dormitory facility for the patients who have come from far off places and they do not have much places to stay. So here the dormitory are given free of cost, and we do give yoga classes both for the patients and the caregivers. As you all know, music does a great extent helps in the healing both of the physical and psychological issues. So here we give a musical support to the patients by the voluntary organizations, which is Suropachara, which conducts the classical music concerts every month, and this is telecasted to all the viewers from outside also, not only from in the hospital but outside also. Next. Nitya Annadana scheme is basically there are 7 free meals given to all the patients in the general ward, which is supervised by a group of dietitians, and which has been personalized. Those depending upon the patient's requirements, we do personalize the diet. We also have patient caregiver support groups and bereavement services. There to take care of pediatric patients, apart from our regular treatment facility, we also have the separate areas for the pediatric age group patients to play around, and also to support them with the art and entertainment programs. Now, since many of the patients, particularly pediatric patients coming from a far off place, like Bidar or Gulbarga, they have financial issues to attend to, and so we give them a free area to stay, that is in the Lakshmi Center, where they stay for as long as the treatment plan is going on, and we also provide them the rations free so that they can prepare their own food. We also are grateful to the CanAid, the sincere volunteer group, which has been helping us for a long time now. They help our patients and also the hospital, and help the relatives around. We are really blessed to have the voluntary group like CanAid. This is roughly the support that have been rendered to the patients over the last few years. In 2012 to 2014, we have given a financial support of 395 patients 395 lakhs of rupees in that year. And in the recent year, totally it is about 5,121 lakhs rupees has been spent on the financial assistance. that is given to the patients. Now, this is in short about our hospital. I would be very happy if you would like to know about our hospital. You can always join our website and send the queries, or you can come over to the hospital, and we will be very glad to receive you here so that you can see our hospital personally. So now I would go to and start my talk on lung cancer. Catch early and treat early is a motto that is common for all the cancers, not only lung cancer, but all the cancers. The important thing is that whenever any cancer is treated, is picked up that early, the cure rates are very high. Looking at the incidence, the lung cancer is the most common cancer all over the world, not only from the point of incidence, but also from the point of mortality. Subsequently, the next one that is commonly seen in all over the world is the breast cancer. And third in the list is colonic cancer. Prostate cancer is also a very important cancer from the point of view of incidence. But as it is relatively less aggressive cancer, I'm not going to address this issue. Now, what is the scene in India? It's about, it was estimated that in 2020, we would have about 88,831 new cases of lung cancer that will be diagnosed, and about 80,523 would be, of the deaths would be because of lung cancer. One thing that is quite unfortunate is that majority of the patients of the lung cancer die within a year of diagnosis, and only about 15 to 17% of the patients live up to 5 years. It is a slightly dismal figure, but that is what is true about lung cancer. It is very common. It is very aggressive cancer, and it usually at time of presentation, it will be in the stage 3 or stage 4. Nearly about 75 to 80% of them present at this stage. And another thing is that average age of diagnosis of lung cancer in India is around 54 years. As we all know, tobacco and lung cancer are very close together, in the sense this cigarette smoking increases the person's chances of getting cancer, lung cancer, by about 15 to 30%. The other causes and the risk factors are that smoking history. In the smoking history, if it is an active smoker, he has about 85 to 87% of chances of developing cancer. And the passive smokers are about 3 to 5% of chances of developing cancer. The other relative factors are the age, other obstructive lung diseases, genetic predisposition, pollutions, and the air pollution definitely contributes a lot to the predisposing you to the cancer of the lung. Industrial work areas like asbestosis and old cases of tuberculosis are the ones that predispose you for a lung cancer. Now let us see what is the problem with the cigarette smoking. So there are 3 components in this: the immunomodulatory toxins like nicotine, carbon monoxide, acrolein, and carcinogenic toxins like polyaromatic hydrocarbons, or the nitrosamines, nickels, cadmium, chromium, etc., and arsenic. Another important factor there in the tobacco or the cigarette is basically this nicotine, acetaldehyde. Nicotine is the one that makes that drives in the addiction into the patient. So you one hand you have the addictive agent in the nicotine, and other contributory factors are the carcinogens which are there in the cigarette, which adds to the problem. Now, if you look at the incidence, this tobacco smoking is maximum in northeastern India, particularly areas like Meghalaya, Tripura, Mizoram. They have the Arunachal Pradesh. There are high incidence of tobacco smoking, and so also the incidence of cancer is high in these areas. Basically, you have two types of lung cancers: the non-small cell and small cell lung cancers. Now, let us see what are the important signs and symptoms of lung cancer. The commonest of the presentation would be cough, a dry cough or a productive cough. Both are important. And productive cough or a dry cough, which has been there for more than 3 weeks, definitely needs to be looked into or investigated. Similarly, cough with weight loss is an important sign which has to be investigated further. Dyspnea is a shortness of breath, which may be in the form of exertional dyspnea, or subsequently when the disease increases, it can be even at rest, there can be breathlessness. Chest pain when the disease progresses towards the chest wall, when the disease infiltrates the chest wall, the pain can be very bad. Hemoptysis is one of the, hemoptysis is basically blood in the once in the sputum. So if the patient notices any little amount of blood also, he usually comes running to the doctor. But unfortunately, most of the times when he comes with this symptom, the disease is usually advanced. Bone pain and fever. Bone pain is definitely suggestive of a disease that is spread to bone, and fever can be a very vague symptom because the lot of infective factors also contribute to the fever, and also patients nowadays, patients with lung diseases also or lung infections also can present with fever, and there can be overlapping of the lung findings. So many times the diagnosis also may get delayed because initially you would be thinking that it is in terms of an infection, which is of course more common. So that could be a reason where we get sort of overlap. The two factors get overlapped, and the diagnosis may get delayed also. How to remove that? Now, what do you do? How do we examine the patient with the lung cancer? Whenever it comes to you, what are the things you are going to do? It's a physical examination to begin with, to looking for the signs of the pulse rate, the basic parameters we look into. Second thing, you usually commonly get a chest X-ray done. Chest X-ray is one that gives the idea, the basic idea of as to the problem here. So now if you can see this area, which is arrowed, that is the area of the cancer of the lung, which is close to the main airway, that is the bronchus. CT scan definitely helps. Why is it moving? I'll get it. Sorry for the interruption. Usually get a CT scan done to look into the details of the tumor, whether it is affecting the to what extent is the size and the number of tumors in the chest or the lung. What is the problem? Soumya? Soumya? Okay. I don't know.
Yes, doctor.
There is some problem with this. Actually, there is someone sharing, controlling the screen there. One Bhavani, something came up in the screen there.
Okay, now actually no one's sharing. It's Shalini who's sharing.
Okay, fine enough.
Yes.
So CT scan, we also look into the whether there is a chest wall invasion or the mediastinal lymphadenopathy or any metastasis. PET scan definitely helps us into looking into the spread of the disease into different parts of the body. But the way to diagnose uh, any of the cancer is taking a biopsy from it. Biopsy is usually done by either doing a CT scan guided biopsy or a bronchoscopic biopsy. In a bronchoscopy, we put in a fiber optic tube inside the airway and go reach up to the tumor and take biopsies from the area. Also, if sometimes if the biopsies are not possible, then we'll take the washes. So this gives the cytology which confirms the diagnosis of cancer. Now, once the cancer is diagnosed, now these are the medical specialties that come into play, where the pulmonologist, radiologist and radiotherapist, pathologist, medical oncologist, and palliative healthcare team. Also is the cardiothoracic surgeons, but I have put it at the last because usually the lung cancer is present in an advanced stage, and the role of surgeon is relatively less. Now coming to the overall survival, it's about, as I told you earlier, it is about 10 to 15%, 5-year survival. So the factors that affect the prognosis are the stage of the disease, the type of histology, the tumor grade, and molecular characterization. Now we have about 3 important modalities of treatment: the surgical therapy, radiotherapy, and chemotherapy. If the lesion is small, then we do a wedge resection, as we take out a small part of the lung, as shown in the upper part of the, that is the apex of the lung on the right side, or a segmental resection, or a lobectomy, which is the most commonly done surgery, or in cases where there is an involvement, a bigger size of the tumor is there, and involvement of the main bronchus is there, then we do a pneumonectomy, that is the full removal of one side of the lung. Now, usually these surgeries will have to be followed with either radiation or chemotherapy, unless it's a very early disease and confined only to the stage 1 or stage 2. The surgical resection alone is adequate, but most of the times it will be adjuvant treatment would be necessary. So chemotherapy is another important modality of treatment that is necessary for our patients, because they present in stage 3 and stage 4 disease. Either it is a single modality of single agent, or a multiple agents are used. And nowadays you have the targeted therapy as well. These are the EGFR or ALK inhibitor. These are the newer drugs that have been tried, which definitely helps in prolonging the life in an advanced disease. So in short, the early disease, usually stage 1 and stage 2, potentially curable, which is accompanied, surgical resection is accompanied by chemotherapy. Now, the patients with the early stage disease that are not eligible for surgery usually undergo radiotherapy with or without chemotherapy. And where there is a stage 3 disease that is slightly advanced, we do a preoperative chemotherapy and postoperative radiotherapy. In between, we may consider doing a surgery also. Now, the important aspect of management of cancer, whether it is oral cancer or a lung cancer, is the cessation of smoking. And actually, it is a multi-modality approach because we, as responsible citizens of the society, we all of us have to contribute to this aspect of the management. As a doctor, whenever the patient comes to me, I do educate him about the deleterious effects of the tobacco, whether it is a smoke form or a smokeless form, and how whether it is the patient and patient relatives are educated by the doctor. As an institution, we have a team of doctors, psychiatrists, and psychologists who look into this aspect and educate the patients and help them in de-addiction also. And in our outreach program, wherever we go to the villages, we educate them about the deleterious effect of the tobacco to the population that we encounter. And we also give awareness programs to the uh, highly susceptible group like school children or the college going children. We do talk to them about the tobacco and the other side effects of tobacco. This as an institution, this is what we are doing. And also, I am sure that responsible citizens and the groups like yours definitely would be contributing a lot towards the in this educating the people or the population about the side effects of tobacco. Yeah, the WHO, all the components like WHO internationally sent WHO, and at the center, central government and also state governments have their roles to play. But as you all know, the legislations takes a long time to work, and they have their own limitations because of the lobbies behind them. So, in my opinion, we all have to keep our uh, work going on and try to force them to bring in the legislative changes as far as possible. In summary, lung cancer is a heterogeneous disease. Most of it present at an advanced stage. Only about 25 or 20% of them present in early stage. And we should try to catch them as early as possible. And wherever it is possible, we have to educate the general population about the deleterious effects of the tobacco and smoking.
Thank you so much, Doctor.
Sorry,
Uh,
Soumya, there is some more coming.
okay. Do we start off with a Q&A session, or do you want to continue?
Yeah, that one. We'll just continue and finish it up, and then yeah. In India, actually, head and neck cancer constitute a significant amount of the cancer malignancies. There are about 40% of all the malignancies is confined to oral and head and neck area. Male is more affected than the females, and this is seen more commonly in the sixth or fifth decade. But there is a change in the trend, and more younger generation is also getting affected because of the uh, tobacco and other related issues. The most common cause is the tobacco chewing. Other risk factors, as I said, tobacco forms about 90% of the oral cancers, and oropharyngeal cancers can be related to tobacco. Drinking of alcohol along with smoking does definitely increase the incidence for the more than 30% of the cancers of the lip have the outdoor occupation with the occupations, those who have prolonged exposure to sunlight. And if you have a improperly fitted dentures, chronic irritation due to this can give rise to chronic ulcers, which can lead to malignancy. Poor nutrition definitely contributes. An important aspect is this human papilloma virus, HPV infection, which spawns a significant amount of cancer in the oral cavity. Here you can see the different contributory factors. Smoking alone causes about 3 to 6%. The betel nut chewing with tobacco, betel nut chewing with tobacco and smoking increases the risk to about 25%. As we discussed earlier, tobacco in the smoke form and the smokeless form here. Smokeless form contains about 28 to 30 carcinogens. Alcohol, actually this acetaldehyde in the alcohol binds to the DNA and brings in certain changes. And also that alcohol can act as a solvent, which facilitates entry of carcinogen into the cells. So that's why it acts more like an additive effect. So the role of human papilloma virus in the carcinogens is established entity. So this affects the younger age group, and it's better outcomes. It has a better outcome. They are more responsive to radiotherapy, and they have a higher survival rate. Now there are a few pre-malignant lesions, what we call leukoplakia and erythroplakia. Leukoplakia is a chronic white colored patchy areas that are seen in the oral cavity. So this is what is a patchy area, which is called the leukoplakia. And here the reddish area is called this erythroplakia. These are the two important pre-malignant conditions of the oral cavity. Here they have, you are seeing a patient whose mouth opening is very badly restricted because of submucous fibrosis. Now, though, coming to the sides of the oral cavity, which is the tongue is the most common area. And coming next is the floor of the mouth. But the tongue cancer, though it may be very small, but biologically it is a very aggressive tumor. Many times we have seen that small lesions, even up to 1 centimeter, lying in the lateral side of the tongue, which may appear very innocuous, but behave very badly, very aggressively, and more so when seen in a younger age group patients. Buccal mucosa are the relatively better cancer because they are not that very aggressive. Now here is a cancer of the tongue, which is involving the lateral border of the tongue, also dipping into the floor of the mouth. Other relatively simpler forms of cancer is a verrucous carcinoma, which is a low-grade type. Now here, this is this is the cancer which is called a verrucous type, which is relatively benign. It is seen near the angle of the mouth. This is another cancer lesion which is seen in the upper alveolus. Now let us see what are the symptoms which are important. A sore in the mouth that does not heal. A pain in the mouth that does not go away. A persistent lump or a thickening in the cheek. A persistent white patch or a red patch, as I showed you that time. A sore throat or a foreign body sensation in the throat which does not go away. So these are the important symptoms that should be addressed to. So difficulty in swallowing, difficulty in moving the jaw, what we call trismus, swelling in the jaw or ill-fitting dentures, loosening the teeth and the pain around the teeth. So these are the or some of the symptoms that are important. Basically, these are the ones, if you see any of these, better to see a dentist. Now, if you have a problem in the oral cavity or a suspected cancer, what do we do when you come to us? The most important thing that is necessary is a incision biopsy. Means to say that there is a, suppose we are going to look at the oral cavity, examine the oral cavity, see what is the contributory factor, and to know whether a lesion that is sitting there is malignant or no, or not, it's basically confirmed by doing a biopsy. This biopsy is usually done under local anesthesia. And once we do a biopsy, we come to know as to whether the lesion is cancerous or not. Similarly, we go further investigating whether the cancer is, if it is cancer, it is spread to other parts of the body or not, or whether it is spread to the adjacent bone or not by doing orthopentagram, chest X-ray, ECG, and other blood tests. Also, we have to add CT scan of the face and the chest to know or to what extent is the spread of the disease, and also to chest to know whether there is spread to the chest or not, because many a times the patients will have the oral exposure to tobacco in both the forms. So when the patient is seen to have a lesion in the oral cavity, it is also possible that he may be having a disease in the thorax as well. Either she may be having a synchronous lesion in the esophagus or in the lung. So we all have to look into all this. The reconstruction is an important part of the management. Suppose I do a surgery for the patient, removing the tongue, part of the tongue and part of the mandible or the bone, called this, so which supports the tongue. If I remove all that, then I need to reconstruct it by using pedicle flaps or a bone flap or composite bone flap. All this has to be thought of. So the reconstruction forms an important part. So the treatment goals are basically to eradicate the primary tumor and the lymph node to which it metastasizes, and to maintain the function and the cosmetic reconstruction. When the stage 1, when the disease is early, our focus is basically on is a surgical excision, where we remove the affected lesion by a wide excision and clear the lymph nodes around. Follow it with radiation if necessary. If it is a stage 3 or stage 4 disease, usually it is a multimodality treatment. As I told you just now, the earlier stage 1 and 2, with no lymph nodes in the neck, we do a wide excision and a small neck dissection, that is supraomoid neck dissection. And this is, if this is followed, if it is a locally advanced disease, we go in for an combined modality of treatment. See, here is a picture of a tongue cancer, which was on the right side, where I have removed the part of the, that is right half of the tongue, and it is reconstructed using a pedicle flap. Here the patient had a disease in the region of the mandible, which has been reconstructed over the, again with the flap. Radiotherapy has a very important role to play in the management of oral and head and neck cancers. If the lesion is very early, we do consider giving a radiotherapy as a single modality of treatment. And sometimes we do add the interstitial implants are given, so that the high dose of radiation is given to the particular area. In addition, we give radiations in the preoperative setting or a post-operative setting as well. In a post-operative situation, we might have heard that after surgery of the tongue and the oral area, patient is undergoing radiation also. So these are the reasons why they undergo radiation. Presence of a nodal disease with an extra capsular spread, whether there is a surgical margins if they are involved, or if the stage 3 or stage 4 disease. These are the areas where, or there are multicentric primaries or more than 4 lymph nodes. These are different reasons why we give post-operative radiotherapy. Now, these are again targeted therapies are all newer medicines that are being tried. They do help in advanced diseases. So follow-up in all these patients, follow-up is an important part of treatment. We usually call them in every 3 months or 2 months, depending upon the requirements. Speech and swallowing therapy is very essential because many of these, see, if I do a surgery for the tongue, the movements get affected, the speech gets affected, swallowing gets affected. So we need speech therapists to help them out. See, as in any other cancer of any other region, the oral cavity cancers should also be detected early. And if they're detected early, the chances of getting a RCDO clearance and their benefits to the patient will be higher. I would like to emphasize on this part of the preventive part of the treatment. See, please look at this, which is easily accessible to all of you. So spend at least 2 to 3 minutes in front of the mirror, at least once in a month, looking at these areas, starting with the upper lip, the upper gingiva, then the inside of the lip and the outside of the lip, then going into the buccal mucosa and the posterior gingiva, that is the posterior aspect of the tongue and the teeth. That is what we call molars. Just see that molar area also. Coming back to the front of the lower jaw, we look at the vestibule and the anterior gingiva. So these are the areas we are going to see initially. Then comes the posterior part of the mouth, oral cavity, that we reach the hard palate, the upper part of the palate that you see there, and the lower part, that is the lower part of the tongue, lateral part of the tongue, and at the end you can check your tonsils also by putting a spoon or an antidepressor down, and you can see the tonsils as well. Now, these are the areas in the oral cavity which are very easily reachable. Only thing is that you may have to spend 2 to 3 minutes looking for all this, and it is very essential to pick up the lesion very early. And as you know the motto, if detected early, the chances of cure is very high. Correct. Now, coming to another important cancer, that is the cancer of the colorectal region, colon and the rectum. Now, this is important because it is, by incidence, it is the second most common thing in the cancer in the all over the world, more so in the Western society. And the mortality due to it is also quite high. Usually in the West, it is the peak incidence is around 7th decade, and male and female ratios are all almost equal. Now in India also there is a gradual change in the pattern, and we are also seeing more of colorectal cancers because of the change in the food habits. Now, who is at risk? It is age, As I told you, older the age, higher the risk. Diet, polyps, genetically predisposed factors if are there, inflammatory bowel disease. Now coming to the age, colorectal cancer is it seems to be associated with diets which are rich in fat and rich in calories and low in fibers. The diet should have good amount of fibers, which is less usually in the Western society, where it was nowadays also in India we are finding it, the change in the type of food that we are taking definitely contributes to the cancer formation. Another important thing is the polyps. The polyps are benign growths from the inner layer of the colon. If you can see this picture, there is a stalk there and there is a small outgrowth that is arising from the polyp. That is arising from the inner layer that's called mucosa. Now, these are the polyps that are important because usually the cancers in the colon, they arise from these pre-existing polyps. That's the majority of them start this way alone. So if you have noticed a polyp, then it needs to be followed up closely. The numbers, the size of the polyp, and then once we do a biopsy, we have to know the type of the polyp that is seen. That also determines what type of cancer the patient may get. Now, if you see this, general population has a risk of about 5%, where those with genetically predisposed, like what we call familial adenomatous polypi or the HNPCC, that is hereditary non-polyposis coli. These are all genetically mutated patients. They have a risk of about 80% or 95%. So as I told you earlier, it is the normal epithelium which has mutated and gone in for a hyperproliferative epithelium. Over a period of time, it goes to form a small adenoma. And then again, there are changes happening as the KRAS mutation, P53 mutation. These are the mutations, the genes that happen. And then it gradually gets converted to large adenoma, and then it goes to form a cancer. Usually this progression from a normal epithelium to or a small polyp to go in for a definitive cancer takes about 10 years. This is how the specimen of colonic cancer looks. In the first one, it's what we call a proliferative type. And the second one below is the one that is called the ulcerative type of cancer. Now, usually this cancer spreads by hematogenous spread through the veins and to the vessels, next through the lymphatics, and also there is a direct implantation and transperitoneal spread. If you see this picture, here is how the cancer seen at different stages. If it is confined to the mucosa, this is called in situ, carcinoma in situ, or it is a T1 lesion which is coming up to the muscularis propria. It's a deeper layer. And then it comes to when it spreads to the much deeper layer of the muscles, beyond the muscles, it is called T3 lesion. And if it's gone up to the lymph nodes, usually it is called T4 lesions. Now, let us see what are the symptoms that these patients present with. If you please have a look at this picture, this is the large intestine, which has got different parts. Basically, we up to this transverse colon, we call it as the right side of the colon, and this is to the left of it is left colon. The reason why I'm showing is the clinical symptoms will vary. The right side of the colon, usually the patient presents very insidiously. There are no symptoms except the generalized weakness, anemia, or sometimes diarrhea. Because this is difficult to pick up unless you are suspicious of a problem like this. You do not, many times, you do not do colonoscopy also. So as a clinician, it should strike to us as that this could be a reason. So because anemia is quite common in Indian population, and also an elderly person coming with anemia, there are multiple other issues also, including nutrition we have to think of. But of course, suspicion should always be there to look for the cancers. If it is in the left side of the left colon commonly presents with constipation, bleeding, PR. Many times these left-sided tumors present quite late because the constipation goes on for long. Patients keep on treating himself with medications so that to get relief of his symptoms. And things go on for long before they get detected. Rectal cancer, they usually give rise to a symptom called tenesmus. Once you have a stool, you feel like going again and again. Some squeezing type of pain may come up. And also you have the blood and mucus in the stools, along with the stools. Now here again, important factor is the change in the bowel habit. Suppose I have regular stools or which has changed to suddenly become constipated, and then it is followed by diarrhea. Then this sort of a change in the pattern of the bowel habit definitely needs to be looked into. Now, another problem that is very commonly seen is bleeding per rectum, which is always labeled as piles. Many times what happens is the patient is not very keen on going to the doctor, particularly
Sir, sorry, sir, you're not audible.
Hello, can you hear me, ma'am?
Yes, yes, it's
Yes, sir.
better now.
sorry. So important thing is that bleeding per rectum, which we usually term as, the patient himself terms it as piles. Actually, piles is a very benign condition, and but what happens is when you neglect a pile, thinking that it is a pile, you go on for long without getting treatment or seeking treatment at all. Then it becomes an issue. So always be, whenever the patient is an elderly age group and has complaints of piles, we do look into it in detail, because there are chances that there may be a tumor sitting higher up and the patient may have some mild degree of piles lower down, and we operate for the piles and still the patient would have the symptoms. So these are the things that we have to look into as a doctor. But as my suggestion would be that any patient with piles definitely should seek doctor's help. It is the next, the onus is on the doctor to investigate further and see what exactly is the cause. An important tool in the investigation of tumor is a colonoscopy. Basically, it is like bronchoscopy, a colonoscopy also. We use a fiber optic or a thin flexible endoscope to see the inside of the large intestine and look for the biopsy, look for the tumor, the extent of the tumor, the multiplicity of the tumor, and also take biopsies. Only when you have a biopsy do you know that it is a cancer. So as it is said that nobody have cancer until pathologist says so. It is very true. Now, as far as the treatment is concerned, after basic investigations and looking at, suppose I diagnose a cancer by biopsy, and at a colonoscopy and biopsy. And then I go ahead with the CT scan to see the extent of the disease and also the extent of the spread of the disease. Then the chest X-ray, the CT scan of the chest also is included in the investigative modality. Now, once it is well confined to the colon, and I know that the stage of the disease, the main modality of treatment of colonic cancer is surgery. Surgery can be an open method or a laparoscopic or a robotic. Now here there are pictures showing the type of surgery that is being done. The right half of the colon is removed. It is called right hemicolectomy, and we bring in the continuity by anastomosing the small intestine to the transverse colon. Similarly, there is a disease sitting at the upper end of the transverse colon, near the transverse colon. We do an extended hemicolectomy. Now, if the tumor is sitting lower down, if you see the picture properly, the tumor is sitting low down in the rectum. That is the area which is very close to the anus. Now, if I have to do a surgery, then that whole area I have to remove. That is called APR, abdominoperineal resection. This surgery is followed by a permanent colostomy. I would like to come to that colostomy part a little later. But there's another area where what we do is a complete removal of the colon in cases like where you have a familial polyposis coli or malignancy in that. Then we remove the whole of the colon, where we leave behind a small bowel coming out called the ileostomy. Now, a prophylactic surgery, when there is a segmental resection, can be done when it's a relatively benign condition like adenoma. We do only segment of the bowel is removed. So we do not do an extensive surgery like what I showed you earlier. Endoscopically also, that using colonoscopy, we can remove the small polyps, which can be single or multiple, and we can definitely remove them and take them for further testing. Now, there are conditions where we have to do a prophylactic surgery. That is, individuals with genetic predisposition. As I showed you that time, the incidence of those people getting cancer is very high. So we do go ahead and do a prophylactic surgery. So in these patients, we may have to do a total colectomy, or sometimes we bring in the ileum and connect it to the rectum also. Coming to the colostomy, colostomy is basically bringing out the a loop of intestine, or what we call a large bowel, outside of the skin through the muscle wall, abdominal wall, so that the motion comes out of the body and it is collected in the bags. This can be temporary or it can be permanent. As I showed you that time, if the tumor is sitting very close to the anus and the whole area has to be removed by surgery, then we don't have a choice except a permanent colostomy. But suppose the tumor is sitting very close to the anus, but not affecting the anus, maybe about 5 centimeters away, or about say 6-7 centimeters away from the anal margin. Yes, then there is a chance that we may connect it back at a primary surgery or at a later date. So in such situations, we do a temporary colostomy as well. So this is how the colostomy appears, and the intestine, the large intestine comes out of the skin, and it is to which the bag is connected, and the fecal matter gets collected in the bag. I would like to many of the patients are worried about carrying on with life with colostomy. I would like to tell them that many of the professionals, even doctors also, lawyers, politicians, many of them are able to carry out their normal life with colostomy. But suppose it is definitely no one wants colostomy, I do understand. But the issue is that suppose it's going to uh, clear the disease completely and you are going to get cured of the disease, then definitely it is worth an operation.
ಅದೇ ಲೇಯರ್ ಆಗ್ತದೆ ಅದ ಪಂದ್ರಿಯಾ ಪ್ಲೀಸ್.
Now there are situations which are important, like the tumor can have an obstruction, tumor can have a perforation, and there can be bleeding in the tumor also. Now these are the complications of the tumor. So these patients with the perforation secondary to the tumor, they have a very bad prognosis. Now, apart from surgery, the other modalities of treatment are the radiotherapy, chemotherapy, chemo and radiotherapy, and palliative care. Now, recommendations for prevention of colorectal cancer is basically the diet, which is low in fat and high in fruits and vegetables and fibers. This is an important thing that you have to keep in mind. The other supplements like vitamin A, selenium, they have to be added. But another important thing is aspirin, which does help in reducing the incidence of cancer. As screening modalities, colonoscopy is an important modality of screening. Apart from that, the fecal occult test, which is an important test that is done. An important thing that you should remember is the more than 1/3 of the colorectal cancer patients cancers can be avoided if the people over the age of 50 had a regular screening done. Most of the colorectal polyps, benign as polyps, and the people who have polyps in the colorectal cancer do not always have symptoms. What I would like to suggest at the end is whether it is a lung cancer or a colonic cancer, the basic things remain the same. Important thing is avoid any of the tobacco or tobacco related getting into the habit of smoking or tobacco related issues. That is the most important thing. Second thing is focus on the diet that you are taking. Don't have to be extra cautious, but at the same time see to it that you have good amount of fruits and vegetables in your diet and your stools don't get constipated. Third thing is do exercises regularly. It applies for both men and women. They have to do regular exercises, at least minimum that is necessary is a walking and for about 30 minutes a day. And there's no shortcuts in all these issues. Yes, reducing meat and fatty diet may definitely help. And whenever there is a symptom that is coming up related to your lungs or your colon or oral cavity, wherever you see any problem coming up, go and reach your doctor at the earliest. I would say one thing very clearly. See, I know the patients are scared to come to the doctors. They fear that patient, he may be diagnosed as cancer. But the issue is, unless I do a biopsy, there's no way no one can tell you that it is cancer. So you have to reach the doctor, and it may so happen that it may not be cancer at all. And you may just be having a small ulcer, and which can be treated with medicines alone. So, but only thing is, it will be known when you come to the doctor. First thing is, give up the fear. Second thing is, it is not necessary that once you go to the doctor, it is not a must that you should undergo a surgery. You can always talk to the doctor. Suppose you're not happy with me, you can go to another doctor, take a second opinion, third opinion, be sure of what you're dealing with, and then go ahead with the further treatment. So many of the patients get scared to come to the hospitals, which I would say that don't get scared. We are all just like your friends. Definitely we will give the necessary information for you to take your own decisions. Now, thank you. And from again, I think some time is there left behind for your discussions. So,
Yes, doctor. Do you have time for any question and answer session?
yeah, what is the time right now?
It's 1:11.
1:11, is it? Oh, yeah.
I believe you
Okay,
have to leave somewhere.
Yeah. I'll have to go do my rounds now.
So how much time do you have left?
If anything is there, I'll answer. Otherwise, I'll be.
Okay, we have few questions, and Retractor Aishwarya will take
Maybe
forward.
5 minutes should be.
Yeah.
Okay.
Thank you, Rotaract Soumya. Hi, doctor. We
Yeah.
have one question from the participant, and they wanted to know whether we can do hair donations at your center.
I didn't get you. What is it? Hair donation, is it?
Yeah.
I would suggest that if you give me your the email or the person who is asking, I'll get back to her.
Okay, sure, doctor. Yeah.
Okay.
Yeah.
Because we all already have certain some this thing going on there, in the sense we have our own system available for the artificial hair that is being given to the patients. But I do not know whether donation and we process it further. That is not being done here as far as I know. But definitely I can help you out on this.
Sure, doctor. Yeah, we'll drop a mail to you. Yeah. Okay, we had one more question, and that was, is cancer genetic?
Yeah, a small percentage of the cancers are genetic. About the breast cancer, about 18 to 20% are genetically attributed to genetics. Similarly, in general, about 10 to 15% of all the cancers can be related to genes.
Okay, doctor. And one last question. How does cancer affect even people who are not smoking? And also, how does it affect for small babies who are just born?
Yeah. That is what is called passive smoking, because it definitely the same amount of if you are very close to the person who is smoking, we definitely pick up those carcinogens which are around into your system. Definitely it has a role. Maybe about that is what been found out is about 3 to 5% of these patients can go into for cancer. And as far as the newborn is concerned, definitely I would prefer him not to be in the scene where the smoking is going on. Definitely it is not going to cause immediate changes in him, but it on a long run, definitely it can affect.
Okay, doctor. That was our last question. Thank you so much.
Thanks a lot for giving me this opportunity, and be very happy if you keep in touch with our hospital. We have our websites, and any further questions or communications can be, I will be very happy to answer.
Yes, doctor. Thank you so much. Thank you, Retractor Aishwarya. Now, Retractor Anupama will take it forward for the vote of thanks.
Yeah, good afternoon to one and all present here. I'm Rotaract Anupama. It gives me immense pleasure to present the vote of thanks. And on behalf of the Rotaract Club of Koramangala and the partner Rotary Club of Koramangala, we'd like to thank our speaker for the session, Dr. Manjunath Sastry, for the wonderful, informative and interactive session that had given us an insight and a better understanding about cancer treatments, prevention and management. We would also like to thank the ZRR Rotarian Satishwaran from RID 3202 for continuing to support us, and to thank all the participants for being an interactive audience. And we'll be looking forward to such amazing sessions in the future as well. Especially everyone who joined from Sophia Interact Club, Rotaract Club of Centennial United, and Rotaract Club of RIMS. So, and we'd like to thank the organizing team, and we look forward to tremendous collaborations with all your clubs in the future as well. And also, we're just sharing the donation link in the chat box, so you can still continue to donate. The donation link will be open up to 11th December. So that's all. And happy Rotraction, everyone.
Thank you all.
Thank you, sir.
Thanking all the participants who joined. We'll be looking forward for all your contributions. And thank you. You're free to leave the session.
Thank you.
Rotractors of Koramangala.
Thank you, doctor.
Yeah, the session is now officially over. You feel free to leave.
Could someone take a group picture? All of you, please switch on your videos for a minute. We can take a group picture. Thank you all.